Okay, welcome back guys for our third and final video for the neuro practice questions. We'll continue along where we left off, just finished delirium. So the next question will be, lacunar infarcts lead to what type of dementia? So lacunar infarcts lead to what type of dementia? How does this type of dementia progress? And how do we abate the progression of this type of dementia? So that's going to be vascular dementia. And remember, vascular dementia, it progresses in a stepwise fashion from progressive small infarcts, which continually take up more and more brain tissue, so they have more and more symptoms in the long term. So vascular dementia, lacunar infarcts lead to that, progresses in a stepwise fashion, and we can do strict hypertension control to abate the progression of this. Next one is a 60-year-old man or a 60-year-old man's family has noticed social, behavioral, and personality changes that have worried them. These include inappropriate gestures and hyperorality. What is this? What will be seen on histology? So that's going to be frontotemporal dementia. Frontotemporal dementia. On histology, we'll see PIC bodies. So PIC bodies on dementia, on histology. And this typically presents in younger patients for dementia anyways, relative to dementia patients. And this is around 60 years old it presents. So that's frontotemporal dementia for that hyperorality and inappropriate gestures and personality changes. Next one, patient has visual hallucinations, falls from orthostatic hypotension, and episodic delirium. His family is concerned about Parkinson's because he's exhibiting many of those symptoms as they have searched around on Google. What is this? So what kind of disease does this patient have? And what do we find on histology for these patients? So for these patients, this is going to be Lewy body dementia. So Lewy body dementia. On histology, we'll see the alpha-synuclein proteins and cortical Lewy bodies. So cortical Lewy bodies. And remember, Lewy bodies is what we found in Parkinson's too, so it's very similar. And here the parents are actually concerned about Parkinson's because they saw his symptoms. But he's also having the hallmark, which is visual hallucinations for Lewy body dementia. And again, we don't want to treat for Parkinson's in this patient because it might make it worse. Okay, next question is, what is the difference between simple and complex partial seizures? So what's the difference between simple and complex partial seizures? What's the Jacksonian march? What's Todd's paralysis? And what are automatisms, and which seizure type do they typically occur with? So simple and complex, Jacksonian march, Todd's paralysis, and automatisms in what type of seizure? So that's going to be simple. Simple, which is retained awareness and consciousness, whereas complex is impaired awareness and consciousness. The Jacksonian march is jerky, rhythmic movements progressing from one part of the limb to another. And Todd's paralysis is neurologic deficits, any kind of neurologic deficit that progresses up to 24 hours after the seizure. So it's after the seizure for Todd's paralysis. And automatisms are repetitive behaviors, and they're accompanied by complex partial seizures. So complex partial seizures for automatisms. Next one is a kindergarten child that has been doing poorly in school. His parents seek advice from you. The teacher says that he's staring off into space at times and occasionally refuses to look or answer the teacher. They notice some eyelid twitching as well. His teacher thinks he has ADHD. What do you think? How would you make the definitive diagnosis in this patient? And what is the treatment for this condition? So this is going to be an absence seizure. And remember, in absence seizures, they have no loss of postural instability. So they might be caught in class like looking out the window or just a blank expression, but they don't have any atonic episodes where they fall on the ground or anything like that. So that's absence seizure, no loss of postural instability. And to make this definitive diagnosis, it's on EEG. And we see that 3 Hertz spike and wave pattern. So that's an important one to know. 3 Hertz spike and wave pattern. And the treatment is ethosuximide. So that's basically, from what I've come across, the only time where we really use ethosuximide. Ethosuximide, that's the treatment for absence seizures. Next one, what does your initial workup include in tonic-clonic grand mal seizures? So tonic-clonic grand mal seizures, what is your initial workup? What kind of things do you want to rule out? How do we find if someone's faking it? So a pseudo seizure. So what labs do we get to see if someone might be faking a seizure? So we want to rule out the underlying causes like hypoglycemia, electrolytes, so we can get a point of care glucose, electrolytes, LFTs, and also an RPR, maybe if we're concerned about neurosyphilis. And to rule out a pseudoseizure, we can get a prolactin as well as a lactic acid, which would be elevated in a real seizure. So prolactin and lactic acid to rule out pseudoseizure. Next one, patient has been seizing for 6 minutes straight and has been refractory to your attempt at using the first-line agent for status epilepticus. What do you do next? So you've already used the first-line agent. It's been 6 minutes, but it didn't work. What should the next treatment be? And what would you use if this second treatment didn't work too? So you have to know the first, second, and third-line treatment for status epilepticus. So that's going to be benzos, first line. Remember, lorazepam is better than diazepam in this situation, or we could use IM midazolam. The second line is phenytoin or fosphenytoin, or you can use levetiracetam as well for second line. And third is phenobarbital or propofol, if that doesn't work. And of course, anesthesia has to do propofol, but third is phenobarbital or propofol. What is the mechanism of action of phenytoin? What are the side effects? So what is the mechanism of action of phenytoin and what are the side effects? So there's a lot of side effects. So the mechanism is it works on voltage-gated sodium channels for phenytoin. So the acronym is phenytoin. P, it's a P450 inducer. H, hyperplasia of the gums and hirsutism. E, erythema multiforme and Stevens-Johnson syndrome. It can also have neuropathies. You want to give it slowly to avoid hypotension. It's teratogenic, can cause osteopenia, inhibits folic acid, and also can cause nystagmus. So phenytoin, those are the side effects. What is the mechanism of action of carbamazepine? So carbamazepine mechanism of action, and what are the few major side effects of carbamazepine? Carbamazepine is going to be sodium channel as well, so phenytoin and carbamazepine both work on the sodium channels. And of course, like we said before, it's a treatment for trigeminal neuralgia. Side effects are hepatotoxicity, SJS. So you must screen patients from Asian populations for HLA-B1502, and that can lead to that SJS if they have that. Hyponatremia and SIADH as well. Next one is what anti-epileptic has the highest risk of teratogenicity? So what anti-epileptic is the most teratogenic? And what is the mechanism of action of gabapentin? So this is going to be valproate. Valproate is the most, or valproic acid is the most teratogenic. And gabapentin is structurally similar to GABA, but its mechanism is actually inhibiting voltage-gated sodium channels. So it's also working on those sodium channels, just like phenytoin and carbamazepine. But it's structurally similar to GABA, so don't get confused. The mechanism of action isn't necessarily to work on GABA. Next one, why do we give thiamine and D5W in an acute seizure? Why do we give thiamine and D5W in acute seizure? What is the notable side effect of lamotrigine? So lamotrigine. So of course, to prevent Wernicke's encephalopathy in the case where delirium tremens might be the case for their seizure. And SJS, so the notable side effect of lamotrigine, it's important to know, is SJS, or rash. So they might say, what is the notable side effect? You might think rash. What is the small vessel disease of the penetrating branches of the cerebral arteries in the pons and basal ganglia? So small vessel disease, penetrating branches of the cerebral arteries in the pons and the basal ganglia. And what is the classic finding on CT in this? Classic finding on CT. So that's going to be lacunar infarcts. So lacunar infarcts, they're small, punched out, hypodense lesions in the central and non-cortical areas. So lower and middle in that brain. Central and non-cortical areas for those lacunar infarcts. And we said those are a risk of vascular dementia as well. Next one, patient states that they're experiencing a temporary shade that came over one eye and then came back really quickly. What is the classic name for this? So they experienced a shade coming down or a curtain coming down on one eye, and then the sight came back very quickly. What is the classic name for this? What is it called if it lasts as long as under 24 hours? So it lasts shorter than 24 hours. What do we call this? What is carotid endarterectomy indicated? When do we do carotid endarterectomy? And what is the ABCD2 score, and what do we use it for? So this is amaurosis fugo, I believe. Amaurosis fugo. And of course, this is a TIA if it's under 24 hours, but most last under 60 minutes. And when do we do a carotid endarterectomy? That's going to be if we find on duplex ultrasound 50 to 99% occlusion of that internal carotid artery. So internal carotid artery, 50 to 99% occlusion, needs an endarterectomy. What is the ABCD2 score used for? So that's used to predict their 30 to 90 day risk for actually having a stroke. So if they have a TIA, we do the ABCD2 score, and we see in 3 to 90 days, are they more likely or less likely to have a stroke? And what constitutes this is A for age over 60, you get a point, blood pressure over 140 over 90, and their clinical presentation. So you get 1 point if they're having just slurred speech, but if they're having motor unilateral weakness, that's 2 points. D2 is duration and diabetes. So greater than 60 minutes is 2 points, whereas under would be 1. And remember, it can be up to 24 hours. Next question, what type of stroke comprises 80% of all strokes? What type of stroke comprises 80% of all strokes? And of that 80%, what percent is embolic versus thrombotic? So that kind of gives it away. What percent is embolic versus thrombotic of that 80%? What's the most important risk factor for this type of stroke? And what is the best initial and the most accurate test? So it's going to be ischemic overall, comprises 80% ischemic strokes, and 2/3 of those are thrombotic, and 1/3 is embolic, like an emboli from AFib or something. Hemorrhagic is 20% overall. Hypertension is the most important risk factor, especially the most controllable risk factor. It's hypertension. And initially, we want to get a non-contrast CT to rule out a hemorrhagic stroke. So that CT non-contrast always first to rule out hemorrhagic. However, the most accurate test is going to be MRI. And so remember, in that first 6 to 24 hours, the CT may be negative and may not show, especially hemorrhagic stroke, but also a ischemic stroke as well. So MRI is the most accurate because the first 6 to 24 hours, the initial CT may be negative. So immediate management with thrombolytics must be done in how long? So how long do we have to do thrombolytic management in a stroke? What are the contraindications to doing thrombolysis? And if a large artery occlusion in the anterior circulation and within 24 hours, what can you do that has the best outcomes? So you can't do thrombolysis, let's say, and it's a large artery in the anterior circulation in the first 24 hours. What is a bigger procedure that you can do? And again, contraindications and when do you do thrombolysis? So under 3 hours, you want to do alteplase, which is a thrombolytic agent. That's under 3 hours. And in some patients, you can also do under 4.5 hours. That's like if they're under 80, if they have an under 25 NIH stroke scale, you can do under 4.5 hours, but typically under 3 hours for alteplase. There's a lot of contraindications. I didn't list them all, but some are a BP of over 185, over 110, which is important to know. A recent bleed, a recent surgery, trauma, bleeding disorder as well. So these are some of the contraindications to actually doing thrombolysis. And if you want to do thrombolytics and the blood pressure is higher than that, you can lower it a little, but you want to keep it relatively high to preserve the penumbra. So that area that's not quite dead yet outside of the ischemic core. And if you want to do that, if you don't want to do thrombolysis, it's over 120, over 220 to 120 if no thrombolytics. And this patient with the large artery occlusion in the anterior circulation, and it's been under 24 hours, we can do a mechanical thrombectomy. So we actually go in there and take out the clot in a large artery occlusion. And here's just a picture to demonstrate the penumbra. So the penumbra is that area around the ischemic core. So if this area gets infarcted, this area can be affected out here. But if we keep the blood pressure up, we want to keep perfusing this area so this can actually survive. Because if we lower the blood pressure too much, then it's not going to get enough flow to this area, and this area can die out too. So that's the reason why we actually want to keep the blood pressure up in this situation. What is the outpatient and long-term management for stroke medically? So what is the outpatient and long-term management for stroke medically? What do all patients with stroke get? So what do all patients with stroke get? So long-term outpatient management is aspirin. So of course, not within 24 hours of doing the thrombolytics, because that's going to increase the risk of bleeding. So aspirin after, though, for long-term management, and clopidogrel. Remember those ADP inhibitors, clopidogrel. And statin equals a stroke. So anybody who has a stroke, they need to be on a statin as well. So next one, a few in-depth questions here. Where is the most common artery to be injured in a stroke? Where is the most common artery to be injured in a stroke? Where is the stroke when they have crossed symptoms? So they have crossed symptoms. And what is crossed symptoms? It's ipsilateral cranial nerve deficits and contralateral motor and sensory deficits. So that's called crossed symptoms. And where would you find the stroke if they do have that? Where would you think the stroke is if they have chiefly vertigo, vomiting, and visual changes, the 3 Vs? Where do you think the stroke would be for that? How about if they have an incontinence and personality changes, as well as symptoms in the lower extremity more than the upper extremity and face? So lower extremity, remember the homunculus, and the upper extremity more than the upper extremity and face. And how about a left-sided MCA will show what kind of symptoms? And how about a right-sided MCA will show what kind of symptoms? So a lot of questions here, but we should be able to see the symptoms and have an idea of what artery and what area of the brain is infarcted or ischemic. So first one's going to be MCA, the most common artery, middle cerebral artery. So that's an easy one to remember. Most common artery is middle cerebral artery. Cross symptoms, that's going to be a vertebro-basilar artery infarct. So remember down in the medulla where the decussation occurs, that's how I think of it. Vertebro-basilar is near the vertebrae, so it's very much in the base, close to the base of the brain. So I remember those cross symptoms are located around there. So this is vertebro-basilar for crossed symptoms. Vertigo, visual changes, and vomiting, that's going to be a posterior cerebral artery stroke. So the 3 Vs are posterior cerebral artery stroke. The ACA, anterior cerebral artery, that's going to be if they have incontinence and personality changes, as well as in the lower extremity more than the upper face. So again, incontinence because of that voluntary urethral sphincter. So one of our sphincters is voluntary, which we can control. So of course, if we're having an infarct in the anterior cerebral artery, that's going to go to the prefrontal and the frontal cortex, and that's where our rationality and ability to make decisions comes from. So if we're having an infarct there, then we're going to lose that ability to voluntarily control the output of urine. So we're going to have incontinence. And of course, personality changes. That's where part of our personality comes from as well, the frontal lobe. And symptoms in the lower extremity more than the upper and face. So remember the homunculus and how the feet dangle over the middle? So the anterior cerebral artery, it kind of also dilates. It also supplies, rather, those two middle parts of the brain there. So, and that's where the feet of the homunculus dangle over. So the sensory and motor aspects of the feet and lower limbs are going to be more affected in an anterior cerebral artery stroke as opposed to the upper limbs and face, which are more on the side of the brain laterally, which would be more MCA. And so left MCA. And the left side of the brain, remember, is where Wernicke's and that comprehensive aphasia is, whereas Broca's and that broken speech. So the expressive aphasia. So the left MCA, that's going to be where these areas of language are, Broca's and Wernicke's, as well as the face and arm as well. So the right MCA is going to be having a more flat affect with impaired judgment and impulsivity. Remember, this side of the brain, the right side, as opposed to the left side, analytical brain, the right side is more contextual and more involved in behavior and self-awareness as well. So we're going to see deficiencies in that. So impaired judgment, in impulsivity, inability to see context, and flat affect and emotion if it's going to be a right MCA. And also, don't forget gaze preference toward the side of the lesion initially. So they might mention in the question stem that they have a gaze preference toward the side of the lesion, and they might tell you which side. So that can be a clue to where the infarct is. Next one, where is the most common location for a Berry aneurysm to occur? Where's the most common location for a Berry aneurysm to occur? That's going to be the anterior communicating artery. So the anterior communicating artery between the anterior cerebral arteries. That's the most common area for that little berry aneurysm to pop out. So next one is a vignette. An MMA fighter comes in after a fight, and his coach states he was kicked in the side of the head, which fractured his temporal bone. This initially caused him to lose consciousness. He got back up and continued to fight, however, but now a day later he is deteriorating and having trouble with routine daily activities. What likely injury did he have? So a couple things important to know. He was kicked in the side of the head, causing a temporal fracture. He initially lost consciousness. However, he got back up and he had his lucid interval and continued to fight, but then he slowly deteriorated a day later and now is having trouble with activities. What is this? In this syndrome, what cranial nerve palsy do you see if they're progressing to an uncal herniation? What cranial nerve palsy? What reflex are we going to see in these patients? What reflex? What will you see in a non-contrast head CT in this patient? What will you see in a non-contrast head CT? And what is the treatment for this condition? So this is going to be rupture of the middle meningeal artery, MMA. So MMA is how I remember it, rupture of the middle meningeal artery from a hit to the temporal bone. So I just think somebody took a kick in mixed martial arts to the temporal bone, and now they have a fracture there, and this caused the bleed there. So MMA, middle meningeal artery is the most common artery from a hit to the temporal bone, which is the most common area. And this causes an epidural hematoma. You might see a cranial nerve 3 palsy, a fixed dilated blown pupil on the ipsilateral side of the injury. So the same side of the injury where they got hit, you're going to see a blown pupil. So that's due to that oculomotor nerve. So oculomotor nerve, again, does some control of the pupil, the efferent aspect of the pupil. So if it's not working, we're going to see that fixed dilated blown pupil on the same side of the injury for that cranial nerve 3 palsy. And the reflex, or the triad that we're going to see, is the Cushing's reflex, which we mentioned before, which is irregular respirations, hypertension, and bradycardia. So the opposite of sepsis. Hypertension, bradycardia, and irregular respirations, and that equals brain dysfunction, of course. So what we can see on a non-contrast head CT, you'll see that lemon-shaped or a biconvex lens-shaped area that does not cross the suture lines. So it does not cross the suture lines in epidural hematoma. You want to do hematoma evacuation for this. Next one, an elderly alcoholic patient with a past medical history of AFib on anticoagulants comes complaining of a week of progressive increase in dizziness and nausea that has not remitted. He has also had a headache. He denies any trauma, but just notes he fell off his chair a couple weeks ago, but it was nothing major, he insists. What is his injury? What is his injury? So a few important things. He's elderly, he's alcoholic, and he has a history of AFib, and he's on anticoagulants, and it's been a whole week where he's been having these symptoms that have been getting a little bit worse, so progressively worse over a week. And a couple weeks ago, he actually had a fall off of his chair, but he insists that it's nothing major. So what is the etiology of this condition that you're suspecting? What is the etiology? What will you see on head CT? And when do we do surgery for this condition? So when do we do surgery? It's not just always an automatic surgery. So this is a subdural hematoma. So subdural hematoma, its etiology is rupture of the cortical bridging veins due to the brain atrophy. So when you have the brain atrophy, the brain's shrinking down in the skull, but the skull obviously doesn't change size. So that puts a lot of tension and makes the veins very taut. So very taut in those cortical bridging veins, and then they're predisposed to rupture at that point, which can lead to that venous bleed. And it could just be one vessel, so it's going to be a slow venous bleed, and that's why it takes time for the blood to congregate in that area of the brain. And that's also why it does cross suture lines and forms that concave crescent-shaped appearance. So it gets into all those nooks and crannies in the brain, and we can see that it does cross the suture line. And also the brain compensates over time, so you may only see minor neurologic symptoms that are slowly progressing. And when do we do surgery for this patient? That's going to be if there's over 5 millimeters of a midline shift or they're overall unstable. So over 5 millimeters of a midline shift. Next one is just going to be an overall image, just so you can have a visual representation of the cerebral hemorrhages here. So again, this is the subdural, and see how it does cross suture lines, and how it gets into all the little nooks and crannies, and it's a venous bleed that's slow over time. Here's the epidural, where it's that lemon-shaped or lens-shaped, and you can see on the outside some edema around the bone as well, indicating that there might have been a fracture there. So again, fracture to that side leads to that, and it does not cross sutural lines. Subarachnoid, you can see it's basically all over from the rupture of that berry aneurysm. In intracerebral hemorrhage, it's inside a specific location in the brain parenchyma here. So next one, well, we kind of gave it away. Next one is a patient states the worst headache of their life just occurred, and they're also having meningeal signs. What is it? So we have to know that one. Worst headache of their life, thunderclap headache, and they're having meningeal signs. What is it? What's the most common cause for this condition? So what is the most common cause for this condition? What are at least 5 risk factors? So we need to know some risk factors of why this would occur. So what are 5 risk factors for this condition? And if the CT is negative in this condition, what do we do next? And what will we see on this? So important to know. If the CT is negative, what test do we do? And then what will we see on that test? So of course, subarachnoid hemorrhage. Classic thunderclap headache, worst headache of my life. That's subarachnoid hemorrhage. And the most common cause is a ruptured berry aneurysm. So we said the anterior communicating artery, that's where the berry aneurysms are most common. It's going to be a ruptured berry aneurysm for subarachnoid hemorrhage. They have a lot of risk factors, hypertension, of course, diabetes, coronary artery disease, importantly, polycystic kidney disease, because they have increased risk of cysts, not only in the kidneys, Ehlers-Danlos, connective tissue disorder, as well as Marfan's, and also smoking, which damages that intima. If the CT is negative, we can do an LP. We can do an LP, a lumbar puncture, and we'll see xanthrochromia. And again, this is only done if the CT is negative and there's no focal neurologic findings or papilledema, anything like that. So that's when we would do the LP if the CT is negative and there were no focal findings. What are some supportive measures for these patients? So you treated the subarachnoid hemorrhage, and now you need to do some supportive measures for this patient. And then also, how do we prevent rebleeding? So important to know, there's also a supportive med that we can get, as well as just supportive measures. And how about rebleeding? So that's going to be stool softeners. We want to decrease their straining so they don't pop anything else. Bed rest. We want to lower their pressure overall. And also nimodipine. So that's a calcium channel blocker, and it's specifically for decreasing vasospasms and also improves neurologic outcomes. So in a berry aneurysm, if it pops, we have red blood cells basically going around, and which could be touching the outside of the other arteries in the circle of Willis, or just other cerebral arteries. So that's going to cause them to vasospasm as well, because the irritation from the contents that were inside the vessel itself. So nimodipine is going to stop that potential vasospasm after the rupture, and that's a good supportive measure for these patients. And how do we prevent rebleeding? That's going to be coiling over clipping. So we can do both, but we can do either rather, but coiling is better than clipping in that situation. Next one, what is the most common cause of intracranial hemorrhage in kids? How about in older adults? So intracranial hemorrhage, what's the most common cause in kids as opposed to older adults? And what is our number one goal in these patients of treatment? So overall, it's hypertension. In kids, it's an AV malformation. So arteriovenous malformation in kids is the most common cause of the intracerebral hemorrhage. And in adults, it's cerebral amyloid angiopathy. So cerebral amyloid angiopathy in adults. Kids, AVM. And overall, of course, we want to decrease the intracranial pressure. And we can do this by IV mannitol. So IV mannitol, it's a big molecule. It's going to pull things into it. So if you put it in the blood, it's going to pull the fluid away from the brain. That decreases the intracranial pressure. Next one, what are the 4 signs of a basilar skull fracture? So what are the 4 signs of a basilar skull fracture? Important to know. Periorbital ecchymosis, that's raccoon eyes. Mastoid ecchymosis, which is battle sign. We can have CSF rhinorrhea and hemotympanum as well, so blood behind the tympanic membrane there. So periorbital ecchymosis, mastoid ecchymosis, battle sign, CSF rhinorrhea, and hemotympanum. And I know it's labeled here, but what would you think this fracture is? So what is this fracture? if you're not watching it, its anterior and posterior arches of the atlas of C1 are disrupted. So there's a fracture through the anterior and posterior arches of the atlas, which is C1. Lateral radiographs will show what? So what we see on lateral radiographs of this condition. So of course, like we said, Jefferson fracture. We'll see atlantodens increased interval. So the increased space between the C2, which protrudes upwards, the dens, and the ligament that comes around the dens attaching to C1. So you'll see an increased interval, which would mark instability of that joint, C1 and C2. And of course, the treatment is going to be to stabilize this with a hard cervical orthosis if that ligament is intact that comes across the dens. So remember, it kind of swivels on the dens, so the atlas on the axis there. Next one, what is this fracture? So we can see type 1, type 2, and type 3 of this fracture. So it should be obvious based on the description of the previous one. What cervical bone is this? And what is the mechanism of injury of this? So what is this fracture? This is, of course, odontoid fracture. The odontoid fracture is C2, and you want to get an odontoid view on X-ray. And it's typically from a whiplash and hyperflexion or hyperextension that kind of snaps off this piece of bone here. And this is what the C1 atlas swivels on, so the head can turn side to side and up and down. What are some conditions that have atlantoaxial joint instability? So it's important to know what are some conditions that have atlantoaxial joint instability. What appears like a fractured odontoid but is not. What is clay shoveler's fracture? So atlantoaxial joint instability, what are the conditions? What appears like a fractured odontoid but it's not. And what is a clay shoveler's fracture? So some of the risk factors are, or the conditions are, Down syndrome, rheumatoid arthritis. Remember we said that before, rheumatoid arthritis. What appears like an odontoid fracture, but it's not, is an os odontoideum. So that's basically an extra bone in that area that appears like a fractured odontoid, but it's not. And you may need C1, C2 fixation for this if it's very unstable. Clay shoveler's fracture, that's going to be a spinous process avulsion fracture at the lower level of C6 or C7, so it's also from forced neck flexion. So if you get a radiograph and it doesn't actually show, if the shoulders or the spine of the scapula is too high that you can't see C6 or C7, then you want to make sure you can see that and get a new radiograph, because you could have a clay shoveler's fracture in that area, and that's that avulsion of the spinous process that pokes out. So it pulls basically off that, like when you're shoveling, pulling up a heavy load can rip off a piece of that bone. Next one, we're almost done. What fracture leads to a risk of anterior cord syndrome? So what fracture leads to a risk of anterior cord syndrome? How about central cord syndrome? And what is subclavian steal syndrome? So what is subclavian steal syndrome? So that's going to be a flexion teardrop fracture. So that makes sense if it's anterior cord. If you're having a flexion fracture and your head's bending forward, where would you think it would hit on the cord? Would be the anterior area. So flexion, anterior, makes sense. Extension's a little bit different. It's not posterior cord, it's more central cord. So you typically get the central cord syndrome from an extension teardrop fracture. An extension teardrop fracture. What is subclavian steal syndrome? So I have a picture here to depict that. But it's basically when retrograde blood flow from the vertebral artery to the same side of the arm due to decreased flow in the subclavian artery due to atherosclerosis. So you can see here, in this subclavian artery here, it's blocked off. So basically what happens for the body to compensate is it increases blood through over here to the brachiocephalic, and then from the vertebral artery, takes even more blood from this vertebral artery on the opposite side, pulls it down this artery to go to this side of the limb. So we'll have obviously different blood pressures in each side. So it's a subclavian steal syndrome. So this subclavian needs to steal blood from the vertebral artery to bring to the other side. So that's subclavian steal syndrome. And the last couple questions. What is preserved in an anterior cord injury? What's preserved in an anterior cord injury? What is Brown-Séquard syndrome? It's important to know what is Brown-Séquard syndrome. And how about posterior cord? And then what do we lose? So what do we lose in posterior cord syndrome? What kind of sensations, etc. do we lose? and what is preserved in the anterior cord injury. So anterior, we have preserved dorsal column. So proprioception, light touch, vibration sense. So that dorsal column is preserved if we're having an anterior spinal cord injury, and that dorsal column brings those sensations up back to the brain. So that's proprioception again, light touch, and vibration. Brown-Séquard, that's a unilateral hemisection of the spinal cord from a gunshot or stab wound that specifically only damages one side exactly of the spinal cord, and it leads to contralateral pain and temperature because it crosses, and ipsilateral vibration and proprioception defects. So if you think about, spinal thalamic crosses, so that's PT, pain and temperature, that's in the spinal thalamic tract, and that crosses, so we're going to have changes to each side, but different ones in each side. So contralateral to the injury will be the pain and temperature loss, but ipsilateral to the injury on the same side of the injury, it's going to be a loss of vibration and proprioception, and we said that's from the dorsal column. And then, of course, if it's posterior, we're going to lose the dorsal column medial lemniscus again. So that's, again, that light touch, vibration sense, and proprioception coming back up to the brain posteriorly. And that will conclude all the questions for the neurology system.